Hi, my name is Brooke. I'm the student pharmacist here at the pharmacy. The patient's chief complaint is increased asthma symptoms, history of present illness. The patient is a 27-year-old African American female with a history of persistent asthma and generalized motor seizures, which is controlled by topiramate. She's been complaining of increased asthma symptoms, but she does not appear in acute distress. She states she has daytime symptoms approximately 3 times per week, uses her rescue inhaler 3 to 4 times per week, but not usually multiple times in a day, and she's awakened by her symptoms approximately 1 time per week. Her symptoms are not tied to exertion alone. She states good compliance to asthma medication and demonstrates proper inhaler technique. The patient presents wondering if a change in her asthma medication is needed. Her past medical history, as I stated before, persistent asthma. This has been going on for about 1 year, and she's on maintenance and rescue inhalers for this. Generalized motor seizures, and this is stable with her topiramate. There's no pertinent family history. Her social history, she denies alcohol, and she was a former smoker, but she quit 3 years ago. It's important to note that her insurance is Anthem, Blue Cross Blue Shield, and Kentucky Medicaid insurance. Medications and allergies. She has an allergy to gabapentin, and the reaction is edema. Her medications that she currently takes is topiramate, which is Topamax 100 milligram by mouth twice a day, fluticasone, propionate, Flovent, HFA, 44 micrograms per puff, and this is 2 puffs by mouth twice a day. And she also takes albuterol, which is Ventolin HFA, 200 milligrams per puff, and this is 2 puffs every 4 hours as needed for shortness of air. And she's also on a birth control that is Trisprintect, 1 tablet by mouth daily. All her immunizations are up to date. She received the flu vaccine in January of this year, and she's also received both the COVID vaccines and the booster. Her physical findings, as I stated before, increased asthma symptoms. She has mild wheezing, no acute distress present, intermittent insomnia, and some lethargy. Her vitals and general information: her blood pressure was 110/72 millimeters of mercury. Her heart rate is 90 beats per minute. Her Tmax is 36.8 degrees Celsius, which is 98.2 degrees Fahrenheit. Her RPM is 18 beats per minute. Her height is 69 inches. Her weight is 158 pounds, which is 72 kilograms. Her BMI is 23.3 kilograms per meter squared, which is normal. Laboratory data and diagnostic tests: her protein was 4.2 grams per deciliter, which is low. Her red blood cell was 5.1 milliliters, which is high. Her creatinine clearance, 120 milliliters per minute, and her serum creatinine is 0.8 milligrams per deciliter. The problem: she has uncontrolled persistent asthma. The evidence of this problem, the mild wheezing that she indicates. She also meets 3 of the uncontrolled asthma symptoms, which is daytime asthma symptoms 3 times per week. She's using a Saba reliever for 3 to 4 times a week. And she experiences nighttime awakenings with insomnia. She meets 3 to 4 of the criteria as stated, which indicates uncontrolled asthma. I determined the patient's step in therapy to be step 2 due to the low-dose maintenance controller, which is Flovent, 160 micrograms, and alternate reliever, which was Ventolin. According to the 2022 GINA guidelines, the Global Strategy for Asthma Management and Prevention, with her current symptoms and status of the patient, she needs to progress to step 3 therapy for asthma maintenance in adults, which includes low-dose maintenance ICS LABA plus a SABA as needed. So I would like to initiate Symbicort maintenance and reliever therapy. Symbicort is also covered on her insurance formulary. I would like to simplify the treatment regimen by using Symbicort because it is acting as both a controller and a reliever, which I will state in a minute. So the goals for the problem, we want to relieve the uncontrolled persistent asthma and symptoms, prevent asthma-related exacerbations, and of course improve the patient's quality of life. The first drug that I would like to recommend would be Symbicort, which is betamazide formoterol. The dose is 80 micrograms per 4.5 micrograms. The route, inhalation. Frequency, she will inhale 2 puffs into the lungs, BID, for persistent symptoms. She may administer up to 2 inhalations every 20 minutes for 3 doses as needed, with a max of 12 inhalations per day or 6 inhalations per exacerbation. The duration will be until the next follow-up with her primary care provider. We can say about 1 to 2 weeks after starting this, just so we can see how she's doing on the medication. I would also like to note that I would like to discontinue the fluticasone, which is the Flovent, and the albuterol HFA, which is Ventolin. So monitoring, of course we want to monitor for toxicity and safety. The most important would be bone mineral density, blood pressure, heart rate, any nervousness, jittery feelings, serum glucose, FEV1, serum potassium, ocular changes. She can also get oral candidiasis, which is a thrush in the mouth, so we want to make sure the patient knows she needs to rinse her mouth after each use of this. Upper respiratory infection, and then signs and symptoms of anaphylaxis, which is shortness of breath, edema, maybe a rash. Signs and symptoms of infection, fever, chills, change in sputum appearance. And then we want to monitor to make sure the drug is working. And this would be, of course, the patient should see a clinical improvement in her respiration, her wheezing should go down, and her FEV1. We want to follow up with the patient, like I stated before, in 1 to 2 weeks, just to see how the patient is doing on the therapy. We can consider stepping down in therapy when her asthma is well controlled, and this would be once it's been maintained for 2 to 3 months. Alright, thank you so much. Let me know what questions you have.